Hello, and thank you so much for joining us for this webinar about mouth care training for people that are residents in care homes. My name's Harriet and I'm a dental hygienist, and this is a really exciting collaboration between Flourish and TePe as part of their oral health collaboration. So we're going to be focusing on looking after people's oral health, and this is a training session for any members of staff that work in care homes across the UK. So the overall aim of this webinar is to make you feel confident to assess the mouth of those that you care for, recognise any abnormalities and provide mouth care to people with a range of differing oral health needs. So in order to achieve this aim, we'll be exploring a series of topics related to the oral health of people in care homes. And these include looking at what optimum oral health looks like and why is oral health important, exploring the NICE guidelines and looking at the expectations from the CQC. We'll do a brief overview of common oral diseases and look at their management in care homes. It's really important to perform an oral health assessment, so we'll look at that in a little bit more detail. We'll look at caring for dentures. We'll explore mouth care as part of palliative and end-of-life care, and also supporting people who are resistant to mouth care. And finally, we'll touch on how to access dental care. So what is mouth care like where you work at the moment? If you just take a couple minutes to reflect on the questions that I've noted down here. So if you think about if you need to provide mouth care, do you have access to the tools that you require? Are there written policies and guidance about how you should carry out that mouth care? And do you have appropriate mouth care assessment tools? We'll explore those a little bit later on, but they might be national tools or ones that you have developed yourself. And do you feel that you've received appropriate training? And do you feel confident to deliver safe and effective mouth care? I hope, certainly for that last question, that if the answer to that is currently no, that after this session, then I hope that your answer changes to a yes. So what is good oral health? I think it's common for people to perceive that perfect Hollywood smile as equating to good oral health, but actually with the rise of dentistry taking place abroad, we're finding that good oral health doesn't equate perfectly straight white teeth. We can see from these pictures here, obviously the goat isn't a typical patient that I would see in general practice, but certainly this lady on the right-hand side, then those teeth, they might look aesthetically more pleasing, but actually she may have lots of dental disease or concerns underneath those sort of perfectly white teeth. And if you think about your own oral health, I'm sure we will have all suffered some pain in our teeth, some bleeding from our gums, and just consider how that makes you feel. It can make you feel sort of like you don't feel yourself. Eating and drinking become more problematic. So oral health is really important, and we'll explore a little bit later on just how important it is. So there are more formal definitions of oral health. So the FDI World Dental Federation defines it as multifaceted and including the ability to speak, smile, taste, touch, chew, swallow, and convey a range of emotions through facial expressions with confidence and without pain, discomfort, or disease of the craniofacial complex, meaning the head, face, and oral cavity. And I particularly like this definition because I think it focuses on the important communications between speaking, but I really like that it highlights smiling. I think we really underestimate how much a smile can impact someone, and I'm sure in your jobs, in your day-to-day jobs, you would much prefer that people were smiley and your residents were happy, and oral health plays a big part in that. So the World Health Organization do something called the Global Burden of Disease Study, and that was last published in 2021. And that states that untreated tooth decay, something called dental caries, in permanent teeth is the most common health condition worldwide. So I think the chances are you will be caring for residents that do have tooth decay, and we'll explore the management of that later on in this session. It's also stating that oral diseases affect nearly 3.7 billion people worldwide. So that's just not tooth decay, that could be things like gum disease, cancers of the head and neck. So really important that we're assessing the oral health of those that we care for. I really like this definition by the Alzheimer's Society, which says that maintaining oral health brings benefits in terms of self-esteem, dignity, social integration, and nutrition. And I'd like to just share a case study with you that happened to a colleague of mine. So an elderly gentleman was, taken into a care home. He lived with his wife previously, but he was requiring some more advanced care. He moved into the care home, and prior to going, he was very sociable. Yet when he moved into the home, he didn't wish to eat his meals with the other residents. He became quite withdrawn. And this was quite distressing for his wife to witness, obviously a huge change for both of them. And my colleague happened to be in the care home and was asked if he would mind going to have a look at this resident. And no one had asked him about his oral health. And actually it transpired that he was a denture wearer, yet he'd forgotten his dentures at home and his wife hadn't realised. And after my colleague encouraged his wife to bring in his dentures, he started wearing them. He would go to the activities in the afternoons and would start eating and drinking much more like he used to. So I think that really highlights the importance of oral health, but also asking those questions. I think dentures can be seen lots of people don't admit that they wear dentures. So I think that's important to ask really sensitively. And again, we'll discuss that later on. So the implications of poor oral health, we've already touched on the fact that it can cause pain, tooth loss, and I think tooth loss can have a huge impact. So it can be the difference between eating and drinking solid foods. And food obviously brings us so much pleasure. It's not just about nutrition, although obviously that is important. It brings us so much comfort. It's a very social thing to do. Poor oral health can really negatively affect self-esteem, as I highlighted in that case study I just spoke about. It also affects the ability to eat, drink, laugh, and smile. And of course, we want our residents to do all of those things. There's also an increased risk of systemic complications such as pneumonia. And again, we'll touch on that later on. So thinking about oral health, the National Institute for Health and Care Excellence, or NICE, published this guidance, this NG48 guidance in 2016, and it covers oral health, including dental health and daily mouth care for all adults in care homes, whether they're resident in care home because of older age or because of learning disability. The Improving Oral Health for Adults in Care Homes is a quick guide for care home managers, and it provides a really useful guide and a brief overview of the CQC expectations for homes in relation to oral health. And it also includes an example mouth care assessment that can be utilised in homes. I have a copy of that further down in the presentation. And the guidance states that all adults in care homes should receive good mouth care by skilled staff. And the recommendations from this NG48 guidance are that there are policies on oral health and providing residents with support to access dental services. There should be oral health assessments and mouth care plans. Mouth care should happen daily. Care staff should have the knowledge and skills to conduct safe and effective mouth care. There should be an availability of local oral health services and oral health promotion services as well. And finally, general dental practices and community dental services can be accessed by residents in care homes. So I'm sure some of you will have heard of this Smiling Matters document. So I've popped these QR codes up in the corners of the slide. So if you scan those, they will take you directly to the guidance. So the Smiling Matters document was published 3 years on from that NG48 guidance, and the CQC, the Care Quality Commission, found that oral health in care homes was unfortunately still not a priority, and people were not always able to access the dental care that they needed. So in 2019, that's obviously pre-COVID, 17% of care homes said that they never assessed people's oral health on admission, and the amount of detail in the care plans varied greatly between different homes. People were not always able to access routine NHS dental care, and therefore the CQC made a series of recommendations. And these include that people who use services, their families and carers, need to be made more aware of the importance of oral care. Care home services need to make awareness and implementation of the NG48 guideline a priority. Care home staff need better training in oral care. The dental profession needs improved guidance on how to treat people in care homes. Dental provision and commissioning needs to improve to meet the needs of people in care homes. And finally, the NG48 needs to be used more in regulatory and commissioning assessments. So the guidelines and the recommendations include things that can be done on the ground in the care homes, but also things that need to happen more at a system-wide level. One sort of interesting thing to highlight is that although the COVID-19 pandemic happened obviously in 2020, it hampered the progress of this report, but it was also noted that it did create opportunities for providers to do things slightly differently. So pre-COVID, online training was perhaps not as prevalent as it is now. So I think that's seen as an advantage of the pandemic. And in 2023, this document was updated. They reviewed all of the care homes. It did say that the pandemic seriously hindered progress in prioritising oral health, but, perhaps some advantages to e-learning. It raised awareness of the importance of mouth care, and that's, fantastic. More homes had a clear policy in place to promote and protect people's oral health. Of course, a huge thing is the workforce challenges that the adult health and social care sector faces. And of course, this has impacted the ability to nominate oral health champions. More staff were receiving specific oral health training, which is excellent. But dental professionals' knowledge around how to manage the complex oral health needs of people living in care homes still required improvement. And I think it's fair to say that's probably still the case today. And there were significant challenges in terms of accessing dental care, which again, I think sadly is still very much the case. So what will the CQ look for in relation to oral health when they inspect care homes? So as part of the CQC's key lines of inquiry, or their CLOEs, care homes are expected to demonstrate how people's day-to-day health and well-being are being met. And there are questions in relation to oral health that support this statement. And these include, do all staff have training in oral health care? Is it covered in induction? Is oral health a mandatory component of regular training? Do staff feel confident in supporting oral health care? Do staff know what to look for to identify deterioration in oral health? Do staff consider poor oral health when assessing reasons behind weight loss, infection, or tissue viability? How do you ensure oral health care is assessed, considered, and delivered as part of a person's care plan? Is the service aware of the NICE guideline NG48? Is oral health assessed fully on entry to the care home in line with this guideline? Is there a detailed oral health care plan in place? And do people have easy access to toothpaste, toothbrushes, and denture cleaning fluid? And finally, do people have access to routine and emergency dental care? So there's quite a lot of detailed questions there, which if you are due a CQC inspection, you should feel prepared to answer. So we'll move on now to look at common oral diseases and their management in care homes. So I hope it goes without saying that there are a plethora of oral diseases, and of course we don't have time to cover all of these, but I think it's important to recognise the most common ones and also to have an understanding of who to contact if you have any concerns. So firstly, fundamental to understanding nearly all oral diseases is to have an understanding of what plaque is. So I'm sure all of you will have heard of plaque. It's that kind of cottage cheese-like substance that builds up on teeth. It builds up really quickly, about 4 to 12 hours after brushing, and it can sometimes be referred to as a biofilm. And we all make it. So everyone in the world makes plaque. Sometimes minerals in our saliva can harden plaque, and that can become something called calculus or tartar. So bacterial plaque is removable by simple toothbrushing, yet calculus or tartar would require professional intervention. So the latest evidence suggests that you can effectively clean calculus or tartar. When I first trained as a dental hygienist, it was seen that you had to remove all calculus, but the guidance on that has changed now. And if someone can effectively clean, it's not considered to cause any more damage. Plaque can also build up on dentures, so really important to maintain good denture care. And it's essential to effectively and frequently disrupt this plaque by effective toothbrushing and cleaning between the teeth. So all of the millions of bacteria that make up plaque work together. And if we separate them by toothbrushing, interdental cleaning, they can't have such an effect. So we're not aiming to kind of kill bacteria, we're just aiming to disrupt them, to stop them working together. And it's pretty gross. So teeth can hold up to 100 million bacteria per tooth, and that's thought to be more bacteria than is found on a dirty public toilet seat, which kind of doesn't really bear thinking about. You can see this image on the right here. There's a lot of soft plaque there, and you can see the impact that that has had on the teeth and the gums. So I'm hoping that you can see the teeth almost have sort of a red halo where the tooth meets the gum, and that's because that bacterial plaque has caused some gum disease, and you can also see that perhaps it might be causing some discoloration of the tooth and some tooth decay as well. So it really is unpleasant. So it's often referred to as a biofilm, and of course biofilm builds up on lots of other medical devices, for example things like endotracheal tubes. And it's a little bit like if you have a vase of flowers and you leave them for a long time, you'll notice that there's this kind of slimy layer in the vase, and that's exactly what a biofilm is, although made up of different bacteria to in the mouth. So dental caries, or tooth decay, is one of the most common non-communicable diseases both nationally and globally. And it's caused by dietary sugars that are broken down by microorganisms in the biofilm on a tooth surface, and that produces acids that over time demineralize the tooth enamel. And demineralize means break down, essentially. So, and it's estimated that of the adults living in care homes in the UK, more than half will have tooth decay. And it's, like I said, multifactorial. So in order to get dental caries, you need 4 different things. So you need a susceptible tooth, time, you need the plaque, and you need the sugar as well. And if you remove any of those things, dental caries won't happen. So for example, you know, we will all have days where we eat a lot of sugar, but that might not happen over time. So we won't get tooth decay from one day of eating a lot of sugar, but if that happens constantly, we will. And so therefore, removing and disrupting plaque is really important. I think it's often controversial to talk about sugar in care homes, and I think, you know, as I said earlier, eating and drinking brings so much pleasure and comfort, and whilst for most of the adult population we would really focus on tooth decay, you know, the frequency that people are having sugar, I think in care homes it's quite different, and we need to be really mindful of that. And of course certain groups in care homes, dietitians will want them to have lots of sugar, and it's not our position as dental professionals to advise against that. It's just really important that we work together. Of course, if we do get tooth decay, it can cause pain, reduced eating and drinking, and really poor well-being. I'm sure if anyone has had tooth decay, it can be really unpleasant. So it's a lot about the frequency of sugar being consumed, and that's really important. So this graph on the right shows how the pH of our saliva is about 6.7, so ever so slightly acidic, ever so slightly alkaline, sorry. When we have something to eat or drink, that pH rapidly decreases. You can see with this orange segment on the graph. And then over time, the remineralization process naturally occurs. Yet if we're constantly eating and drinking, we will never come out of that orange. We will always be in that kind of critical stage where tooth decay might happen. And essentially it works by the bacteria that are present in plaque convert any sugar in our diet into acid, and when this acid meets the tooth, it weakens our enamel, which is the outer surface of the tooth. And enamel is the hardest substance in the body. The only thing that can kind of get through enamel in terms of the things that aren't sugar is diamond. So when you have a filling at the dentist, they will use a diamond, something called a diamond burr, in order to drill through enamel. And that process of the acid weakening the tooth is called demineralization, and each acid attack lasts until our saliva neutralizes the acid. So our saliva naturally wants to do that. We don't necessarily need anything in addition to it, and then it begins to repair the damage, which is called remineralization. But that process takes quite a long time, and repeated and prolonged acid attacks will eventually lead to tooth decay. So what are the signs of dental caries? Of course, pain, a toothache that presents as a continuous pain or occasional sharp pain, but not everyone that is resident in a care home will necessarily be able to communicate that they are in pain. So things like frequent touching of the face, suddenly wanting to avoid eating or drinking, particularly sweet things, or hot and cold, can be an indicator that there is some decay going on. Discoloured spots on the teeth, these can appear as brown or black or grey, and bad breath or an unpleasant taste in the mouth. You know, bad breath is particularly challenging because it can be very unpleasant for everyone involved. So moving on to gum disease. So gum disease again is caused by a buildup of plaque on the teeth, and it's most likely caused by poor oral hygiene, and by that I mean inadequate toothbrushing and interdental cleaning. So in my role as a dental hygienist, when I see patients in general dental practice, lots of patients will tell me that they are brushing twice a day and that they are cleaning in between the teeth regularly, yet they still have gum disease. And actually it might just be simple tweaks, like you're not using the correct toothbrushing technique, the toothbrush you're using isn't the best it could be, your interdental cleaning brushes aren't quite the right size. So it's just important to try and find the right tools for the job and use the right techniques as well. So it begins as something called gingivitis, which is what you can see in this image on the left. So similarly to the previous image, you can see that the gums are quite red and inflamed around the teeth. And you can imagine that if you were to brush those, they would bleed. So it's, you know, all gum disease will bleed, and that's not that you or the resident is doing anything wrong. It's kind of, I describe it to my patients as it's almost part of the healing process. And if you have gum disease, you should expect a little bit of bleeding to start with. It can look quite alarming, you know, blood mixed with saliva can look sort of worse than it is, but obviously something to keep an eye on. And if you have residents that are taking anticoagulants, things like warfarin, rivaroxaban, that can obviously make it look much worse. Over time, that bleeding will settle down as long as you have really good oral hygiene. So if it doesn't settle, if say for example your oral hygiene doesn't improve, there are other risk factors such as smoking, the disease can progress to something called periodontitis, and this is irreversible. So you can see in these pictures on the right, you can see how actually the gums look quite pale pink. They look relatively healthy. There's not too much inflammation, but I would describe this person as looking a bit long in the tooth. And chances are they've had treatment for their periodontitis, which has caused this. But if you look at this X-ray on the bottom, you can see where the bone holds the teeth in place, and actually for some of the teeth they look like there's not very much bone holding them in at all, and that's as the result of periodontitis. So that can lead to really mobile teeth. And mobile teeth can feel very daunting to clean for someone else. But the best thing to do is to use a finger to very gently press on the biting surface of the tooth. Just apply very, very gentle pressure, and that will stabilize the tooth and you can gently clean around it. The only thing I think to be aware of is, you know, if you're worried that someone might bite you, that's obviously quite a risky thing to do. So you could use something else that's not your finger, such as the other end of a toothbrush, or you can get bite guards. There's all sorts available to kind of support you in doing that. What are the signs of gum disease? So red and swollen gums, like we saw in the pictures, bleeding when brushing and or cleaning between the teeth, bad breath, an unpleasant taste, and loose teeth. But the bacteria specifically involved in periodontitis have been linked to a variety of systemic health conditions. So I mentioned earlier on in the presentation that poor oral health can cause things like pneumonia, and it's a very specific type of bacteria that's involved in periodontitis that that is linked with these systemic health conditions. And it's thought that periodontitis will increase the risk of things like kidney disease, certain cancers, may cause adverse pregnancy outcomes, particularly low weight preterm babies, Alzheimer's. So studies have shown that this particular bacteria, something called Porphyromonas gingivalis, or PG, has been found in the brains of patients that have Alzheimer's. There's a link with rheumatoid arthritis and a potential link with COVID-19 as well. Studies showed that during the pandemic, if you were admitted to intensive care with, if you were admitted to hospital with COVID-19 and you also had periodontitis, you were much more likely to end up intubated in intensive care. And what sort of other problems that it could cause are things like heart disease, increased risk of mouth cancers, potential strokes, lung conditions like the pneumonias, and also diabetes is really strongly linked. So the link with diabetes is bidirectional, meaning that poorly controlled diabetes can influence periodontitis, make it worse if poorly controlled, but also the unstable periodontitis can lead to poorer glycemic control. So therefore, if you have a resident who is diabetic and no matter what you try, you cannot get on top of their glycemic control, have a think. Do they have advanced gum disease? Is that potentially causing a concern? And if you suspect that that might be the case, or you'd like to have a bit more information, then seeking the advice of a dental professional will help, they will help guide you through all of that. So how do we prevent tooth decay and gum disease? So good oral hygiene is vital. So when I say oral hygiene, I mean effective toothbrushing, effective cleaning in between the teeth, and use of a fluoride toothpaste as well. So toothbrushing definitely twice a day, once last thing at night before you go to bed, and then on one other occasion. So it doesn't have to be first thing in the morning. And actually, I think probably in care homes, it's not necessarily practical to do it first thing in the morning. There's usually a lot of other things going on. Ideally, we want to wait about half an hour to an hour after eating before brushing. So if we think back to that curve with the remineralization and demineralization, if we brush our teeth when we're in a demineralization phase, we will very, very slowly remove tiny amounts of enamel every time we do that, which over a long term can cause sort of lots of tooth wear like erosion, which can be very sensitive. So cleaning in between the teeth is best done with an interdental brush. So these are the gold standard of interdental cleaning. Floss should only be used in areas where interdental brushes don't fit. Excuse me. But I question whether it's practical for people in care homes to have, to clean in between their teeth. I think if people are independent and they're able to, it's absolutely the right thing to do. And I think if it's easy for care staff to clean interdentally, again, fantastic. But I think you have to use a little bit of judgment here as well. So we need to brush using a fluoride toothpaste, and that needs to contain between 1,350 and 1,500 parts per million of fluoride. The higher fluoride toothpaste is available on prescription, and actually that's really beneficial to people in care homes. Oh, excuse me. It's important that after brushing we spit out any excess toothpaste, but that we don't rinse, because that will reduce the effectiveness of the fluoride. And when I say we don't rinse, I mean we don't rinse with mouthwash or water. Mouthwash can be used at a separate time to brushing, but there are some considerations with using a mouthwash and recommending that to residents. So is it alcohol free? Ideally it should be. Mouthwash can feel quite unpleasant to use, and you need to make sure that the person can spit effectively if they're going to use a mouthwash. When you look on the back of a toothpaste tube, there will be all sorts of different ingredients, but at the bottom or somewhere in there, it will say contains something to do with fluoride. It won't necessarily say sodium monofluorophosphate, and then it will have the number and the ppm, meaning the parts per million. So just really important to have a look at that. Toothpaste doesn't need to be expensive as long as it has the fluoride. That's really important. Some toothpastes have a foaming agent, and this one does. You can see it says sodium lauryl sulfate. That can be particularly unpleasant to use. It can really dry the mouth, and people with swallowing difficulties can really struggle. So to have a sodium lauryl sulfate free toothpaste can be really important. They're quite widely available. A simple Google search will kind of lead you to brands and supermarket owned brands that don't have that in them. So what makes a good toothbrush? So definitely a small head and soft to medium textured bristles. In my experience, lots of people prefer to use a hard textured toothbrush because they feel that it cleans the teeth better. But when you look inside the mouth, they actually cause quite a lot of damage there. It can be manual or electric, but if it is electric, ideally it needs to be rechargeable. A battery powered toothbrush where you change the batteries doesn't tend to have enough power, and an electric toothbrush ideally needs to oscillate and rotate, so have a head that kind of goes round rather than bristles that just vibrate. Replace the toothbrush regularly, usually every 3 months or when it appears worn. So toothbrushing technique. So this image on the left shows that the bristles are placed at a 45-degree angle to where the gum meets the tooth. That's absolutely essential because that's where the bulk of the bacteria will sit and where they can cause their damage. On the right-hand side, you'll see that the toothbrush is just placed flat on the teeth. That's not going to be so effective. So ensure that the toothbrush is angled correctly. And you can see down here as well, if you're angling up towards the tooth rather than down towards the gum, the bristles won't effectively get in between the teeth as best they can. Whereas you can see on this image on the right hand side that will be a much more effective way of brushing. And then you want to do small circles. So you don't really want to scrub, but just small circles on the gum margin will be really effective. So we'll move on to talk about sugar. So, as I said earlier, the advice is best given in conjunction with a dietitian, and residents in care homes do tend to have a higher sugar diet. But in an ideal world, we need to reduce the amount and the frequency of sugar that we consume. Ideally, it should only be consumed at meal time, so 3 meals a day, but of course that's not always practical. But it is really important to avoid it in the last hour before bed, and that often seems more achievable, I think. There are other things that we can control. I think sugar is perhaps one of the more challenging things to control in a care home. But like I said earlier, ensuring that there's good oral hygiene, really good fluoride availability. So if you do think, and if a dietitian has recommended someone has a really high sugar diet, it's definitely worth speaking to the person's dental team to see whether they can be prescribed this high fluoride toothpaste, because that will make a huge difference. You could also consider more frequent mouth care. So more frequent disruption of that plaque, but of course bearing in mind not to do it within half an hour to an hour after eating. So xerostomia, or dry mouth, affects approximately 1 in 5 people, but maybe more in care homes. I'm sure we've all experienced a slightly dry mouth at some point, if we're dehydrated or we're anxious, and it can feel really unpleasant. So it can feel like the mouth is kind of made of sandpaper, and the saliva can be really sticky, and the lips and the inside of the mouth really dry. So, your tongue might stick to the roof of your mouth. Your lips might crack and be really painful. And there's all sorts of causes, and these include being elderly, menopausal women, the sort of hormone imbalances can cause a dry mouth, polypharmacy. I'm sure nearly every resident in a care home is taking multiple medications, and the more medications you take that can cause a dry mouth, the worse the effects will be. And it's simple medications as well. So antihistamines, hay fever tablets, paracetamol, all list dry mouth as a side effect. Certain illnesses such as Parkinson's, Alzheimer's and diabetes, dehydration, stress and anxiety, and it can be really debilitating. It's also worth noting that if you have a resident that has a severe dry mouth, it can affect their ability to take medications because the tablets will stick to that the inside of their mouth, their oral mucosa. So it's worth checking, if you give someone with a dry mouth a tablet to take, it's really worth checking that they have managed to swallow it and they haven't just sort of parked it in their soft tissues. Fortunately, it's quite easy to manage. So water can provide temporary relief, but it often isn't enough. It doesn't really kind of get to the underlying cause of the problem. There are lots of different mouthwashes, gels and sprays that are available either over the counter or on prescription. You do need to err some caution with some of the products because some contain animal products such as pig mucins or milk proteins, and they may not be suitable for certain groups. Products are often available flavoured or unflavoured. If you have a really dry mouth, using a flavoured mouth rinse or spray can make the tissue sting and can feel quite sore. Mouthwashes are even more beneficial if they contain fluoride, as people with a dry mouth are at a higher risk of decay. And just think about how you would manage dry skin. So water might provide temporary relief, but it won't be enough. And if you apply a moisturiser to your arm, for example, if the skin is dry, you don't just pop it on the top and leave it there. You really have to rub it in. And it's exactly the same with using a mouth gel. Obviously, a mouthwash is slightly different because you would just rinse that around. But if you use a mouth gel, you can either apply it with a finger, a clean finger, and just very, very gently rub it in. The smaller the better. The larger, it's easy to think, oh, I'll use a lot because the mouth is really dry, but actually that can make it worse. So a really small amount, but thoroughly rubbed in. If you're not happy to use a finger, if you need to put some on the palate, for example, using something like a silicone applicator, like the one in the image here, can be really beneficial. So pink sponges are a controversial topic, as I'm sure you're all aware. So the Medicines and Healthcare Products Regulatory Agency, the MHRA, do have an alert against their use and they are banned in Wales. However, they may still have a place, perhaps in certain circumstances, such as end of life, but there are alternatives that are available. So, for example, the silicone mouth sticks that I mentioned earlier, a 360-degree toothbrush can be really useful. But actually just a really soft-headed toothbrush is a fantastic alternative. So there are alternatives out there, and it's an individual discretion as to, in England certainly, whether sponges are used. And I should say that not all sponges are pink anymore. They may be different colours. The alert is against all sponges, but you do need to sort of think whether they are appropriate to use. Of course, there are so many other oral conditions. When conducting an assessment of the mouth, it's really important to also look at the soft tissues in the mouth. So we focused a bit on teeth, but actually the soft tissues will include things like the tongue, the roof of the mouth, the back of the mouth, in under the tongue, inside of the cheeks. And I'm sure you will all see oral thrush all the time. So really important. You can see oral thrush in this image here. Important to kind of raise that with medical teams and have that managed appropriately. But it's also important to be aware of oral abnormalities and know when to refer. So if you see something in the mouth that looks suspicious or just doesn't look quite right, and it's been present for longer than 3 weeks, definitely seek medical or dental support there. Consider taking a photo if you can. Ideally, if you can take a photo with a ruler so that you can assess whether it gets bigger or smaller or changes. Unfortunately, the majority of early oral cancers are often painless. So residents might not be aware that something's going on. So that really highlights the importance of doing a thorough mouth care assessment. Which nicely leads me on to how to perform an oral assessment. So we'll explore now how to thoroughly assess the mouth and to record your findings. So why is it important to conduct an assessment? So we need to know those who are at high risk, and that's high risk of things like the oral problems like tooth decay, gum disease, high risk of aspiration, of developing cancer, etc. So really important to do that. Highlights the amount of support required. For a lot of people, they might just need their memory jogging, or they might not be able to reach their toothbrush. They might need it passing to them. So not everyone will require you to brush their teeth or deliver mouth care for them, but you still need to make sure it's being offered. Compliance with the CQC, really important continuity of care. It's absolutely an essential part of personal care. And unfortunately, if it's not recorded, we have to assume that it's not been done. When I've audited care homes and looked at mouth care practices and hospitals as well, often, mouth care, you can kind of see that it's been done, but if it's not been recorded, then we just have to assume that it hasn't. So this is the oral health assessment tool that is in the NG48 guidance, and it's a really simple, useful tool to use. So I shall, hopefully you can scan the QR code earlier in the presentation, and it will take you to have a look at this in a bit more detail. It must be completed within 24 hours of admission to the home, and then ideally reviewed every 7 days, or if something changes. There are various other assessment tools available. Often homes will develop their own because it links up to your own kind of your system. You might have different residents that actually require different levels of care. In short, you need to make sure that your local infection prevention and control policies are adhered to before, during and after you do your assessment. Hand washing, appropriate PPE. A light source is absolutely essential. So something like a pen torch. Involve the resident, discuss their preferences and likes or dislikes. Some people are adamant that they absolutely hate an electric toothbrush and they will only use a manual. And it helps you to determine the level of support that they require. Ask about dentures. Not all residents will have brought them or wear them, even if they do have them. And if they're not wearing them, dig a little bit deeper into that. Are they sore? Do they need adjustment? Do they not fit anymore? Has someone lost a lot of weight and actually their dentures are too big now? And also ask about their current access to dental services, things like their last visit, when you do have an appointment, how do you get there? Simple questions like that will just help you to build a really clear picture of someone's oral health. And what are we looking for? So I always think it's easy to start with what you can see externally. So looking at the lips, they should be pink and moist. The same with the tongue. The tongue shouldn't be heavily coated. It should look nice and clean. The teeth and gums, again, look clean. Teeth aren't broken or loose. Gums aren't bleeding or inflamed. The cheeks, the palate, look under the tongue. It's quite a common sight for oral cancers under the tongue. So you might need to use a little bit of gauze and just gently lift under the tongue. But it should look clean, saliva present and looks healthy. And again, dentures look clean and comfortable. It's absolutely vital that both the dentures and the mouth are cleaned daily. So it's vital to record all your findings and when mouth care has been done. So even if you offer mouth care and it's declined, it's still really important to record that. Then someone coming along to see the resident later can offer again, but it's just absolutely vital to record everything. There's all sorts of things that can be seen in the mouth. So in this picture on the left, we can see that plaque sitting on the gum line. The mouth looks a little bit dry as well. In the sort of top of the image, there's something that potentially looks a little bit unusual. Usually when I deliver this presentation, people will say that they think it's an ulcer. And I think, I sort of question people as to how they know that. Ulcers have that classic kind of white centre and then that red ring around them. And I would argue that this doesn't have that red ring. I don't know what it is, but I would certainly be keeping an eye on it. Lots of broken down teeth. I think it's fair to assume that this is the mouth of a person that hasn't received regular dental care. Whereas if we look at the image on the right, yes, they do have fillings, but actually that's a sign that they are regular attenders. You can see the saliva pooling under the tongue. The teeth look really nice and clean. There's a little bit of staining on some of the premolars, and often people think that that's decay, but actually, it doesn't look soft. I think that looks a very healthy and clean mouth. The lips potentially a little bit dry, so ensuring that the lips are nicely moisturised is a really important part of mouth care. So in this section, we're going to look a little bit at how to care for different types of dentures. So dentures are becoming less common. These days, it's not the norm to necessarily have full dentures, whereas some years ago it would have been. It's really important to assess whether residents wear dentures and record this. Lost dentures can have such a negative impact. They're really costly to make. They take a long time to remake, and that might be someone without their dentures for months, which might mean that they can't eat or drink. Their self-esteem is really negatively impacted. They don't want to smile or have any social interactions. But residents love to, screw them up in an old piece of tissue and leave it on their lunch tray. And of course, it goes straight in the bin. So just being mindful of all of those things. You can get denture marking kits, which are widely available online, and that's a really good idea for a home to write. You have a little pen and you just write the resident's name in an unseen place on the denture. Cleaning dentures is vital. If dentures aren't kept clean, it can cause oral thrush. They should ideally be left out overnight and cleaned with soap and water, but not toothpaste. So toothpaste is quite abrasive, which is why it helps to clean our teeth so well, but it can, over time, just scratch the acrylic that the denture is made of. So soap and water is perfect. In my experience, people don't particularly like to see you clean their denture with soap and water. So I tend to kind of stand, so people can't see me just using a bit of washing up liquid or a bit of hand soap and water. And of course, if you thoroughly rinse it, there'll be no taste from what you've used. They should be stored in a named denture pot, and denture cleaning solutions are really effective, but you should only use those by following the manufacturer's guidelines. So in order to clean the dentures, carefully take it out. Make sure you have a basin filled with water or a bowl with water. If you were to drop a denture into a dry basin, chances are it would break. They are quite fragile. So just if you fill it with water or place a flannel in the basin first, that can be really helpful. So you do need to take some care with denture cleaning tablets and solutions. There have been incidents in care homes where residents have eaten denture cleaning tablets because they thought they were mints, and they are bleach. And you shouldn't leave dentures soaking for more than the recommended time, but ideally for some residents out of their way. Again, we found that more so in hospitals, but if patients are nil by mouth, yet they see this, what they think is a glass of water, they will drink it, and it's actually got the denture cleaning solution in and is really dirty and very dangerous with the chemicals in it. So oral care is absolutely vital throughout the life course and a really, really important part of palliative and end-of-life care. So we'll now look at that in a little bit more detail and how the focus of mouth care changes at the end of life. So I've spoken a lot about, prevention. So if we have good oral hygiene, we're using fluoride toothpaste, we can prevent the tooth decay, the gum disease. Yet actually at the end of life, the focus very much moves from prevention to comfort. So when I refer to end of life, I refer to the last 12 months before death. But actually, there's still a degree of prevention that needs to be done there. But as we move into the last weeks and days before dying, then the focus is very much on comfort. So oral symptoms can be as a result of the dying process or due to the polypharmacy of the treatment of the condition. And they can include things like xerostomia, difficulty swallowing, bad breath, ulcers, mucositis, which is inflammation of the soft tissues of the mouth, and pain as well. It's common practice, or it used to be, to use lemon and glycerin swabs in end-of-life care, mouth care, but actually we've shown that those are really drying, so they shouldn't be used. It's still really important to ensure optimum oral hygiene. I think it's, the focus for mouth care does change, and it's actually really important for loved ones to not witness their relative or their loved one have bad breath, because it's such a barrier to getting close to someone, and it's horrible to have your lasting memory of someone you love dying, but you don't want to get close to them because their breath is really unpleasant. Taste of Pleasure is such a lovely initiative. It was done by, introduced by Shrewsbury and Telford NHS Trust. And we know that the desire to eat or drink at the end of life usually decreases. That's a very natural response as the body's organs slow down. But the best way to provide comfort is to provide really frequent fluids whilst people are able to drink. And then when that's no longer possible, to keep the mouth moist. So I spoke earlier about the different gels and mouthwashes and sprays that you can use to moisten the mouth. Yet actually Taste of Pleasure uses someone's preferred drink and taste. So it's quite common and particularly lovely. Lots of people choose something like champagne because it brings happy memories of things like weddings and celebrations. And I've seen relatives use champagne to kind of toast that person's life, and that creates such an incredible memory for those people. But you could also use things like cooled tea, juice, whatever that person's, preferred taste is. Obviously, you'll need to check guidance on alcohol, but a really lovely thing to do. And it can also be carried out by the family members. So particularly at the end of life, family members can feel like they don't know what to do, and that can be quite hard. Yet involving them in mouth care brings their loved ones so much comfort that it's a really powerful thing for relatives to get involved in. So lots of people will resist mouth care and any level of personal care, but we're obviously focusing on the mouth here. And people may resist mouth care for a variety of reasons. So applying different approaches is really important. So care-resistant behaviours refer to actions taken to avoid receiving assistance or care activities. And that might include things like pulling away, attempting to leave, becoming really agitated or aggressive, and that could look like biting or hitting. In terms of mouth care, pushing the toothbrush away or clenching the mouth shut. And the behaviours are really defensive because they perceive you as a threat, but that can result in the omission of mouth care, which is not what we want. So there are various strategies to reduce care-resistant behaviours, and I'm sure that you are aware of these and you're doing these already, so I apologise if this is teaching you to suck eggs. Be friendly, have an approachable demeanour, speak slowly, use a low pitch, use gestures, try to avoid kind of that elder speak if you're working in an older person's care home, can be quite patronising. Allow time for a response. People might be processing what you've said. Really simple things like, is the resident wearing their glasses? Are their hearing aids fitted properly and are they working? Be very gentle. Use a bathroom where possible. Most of the time when we're in our own home, we will brush our teeth in the bathroom over the bathroom sink. Yet when we move to a hospital or a care home, often we're asked to do these things in bed, and it might not feel natural. So it might just be that the environment is making people forget or perceive it differently. Ideally, encourage independence before assisting, and you could also use some distraction techniques like talking or singing. So bridging is a technique where you will hold an associated object, such as another toothbrush, and that might be enough to encourage the resident to then brush their own teeth. You could do something called chaining. So you start the task, then ask the person to join in. For example, you could put the toothpaste on the brush and then give it to the resident. Popping your hand over the other person's hand and then gently guiding them often makes people feel like they have a little bit more control. Using a mirror, really helpful if the person is particularly prone to kind of clamping shut. If you use a mirror, that can really prevent them from doing that. There are also different tools that you can use. So, for example, if people have real difficulty gripping a toothbrush, the handles are often quite thin, you can adapt the handle. You could wrap a flannel around it, for example, or I've seen people cut sort of a small hole in a tennis ball and pop the toothbrush in that because it gives you something easier to grip onto. Electric toothbrushes often have larger handles that are easier to grip, so that's something to bear in mind. You could also get things like a three-headed toothbrush, and that can be really useful for people with limited mouth opening. So finally, access to dental care. At the moment, to be honest, often quite a controversial and political topic. The NICE guidelines, the NG48 guidelines, do state that care homes must make dental appointments for residents if necessary. And I echo what I said before, you need to discuss with the resident, are they registered with the dentist? Where is that, are they regular attenders? Because of course, not everyone throughout their life will have attended the dentist regularly. And it's not your responsibility to reverse years of dental neglect, but you do need to be mindful of the impact that can have to a person. So if the person is registered with a dentist, this should ideally be your first port of call if someone needs some dental care, whether that's routine or in an emergency. If the person isn't registered, NHS dentists that are taking on patients can be found using the link here or by scanning this QR code. Care home residents may be eligible for referral to the community dental service if they are unable to be seen at a general practice and they meet the local referral criteria. And that local criteria can be found by looking online for your local community dental service. Urgent dental treatment ideally should be sought from NHS 111 if someone isn't registered with a dentist. But if you need emergency dental help, such as a resident has uncontrolled bleeding from the mouth, there's swelling around the throat or the eye that's rapidly worsening, or there's trauma, you should seek help at your local emergency department. So unless exempt, people in care homes will have to pay for their NHS dental treatment. You can look online, there's some information about whether people may be eligible for free treatment, but the majority do have to pay. There's some really useful resources here. So the tips and advice for oral care is beneficial to yourself, but also will give you sort of some videos and some tips as to how to care for your residents. And then this other QR code is the Oral Health Toolkit for adults in care homes, which has further training resources and is just a fantastic toolkit for giving you further information. Thank you so much for listening to this webinar. I apologise that I've developed a cough as I've gone along. But I'm really grateful for you listening, and this is such an exciting collaboration between Flourish and TePe, and there'll be lots more oral care things to come. So thank you.